Very good evening, one and all. I'm absolutely delighted today to moderate today's webinar session. Today's topic is a very, very rare disease that we will be dealing in our practice, but it is an important problem in India. Okay, cystic fibrosis, which is probably across India, even the best of the best pulmonologists would have seen only few cases, handful of cases. So on the token, so the idea of doing this webinar, it has come to my mind probably a month back when I was watching this movie, Hi Nana or Hi Papa in English, in Hindi. It is basically a Telugu movie, and where the concept of cystic fibrosis, affected child, what few challenges that she has faced, and ultimately this kid grew up after a lung transplant. So not too much discuss about the movie, and today to discuss and then to share the valuable insights of cystic fibrosis, we have a star pulmonologist from across India for giving their opinion, how to diagnose, how to manage, and what are the various key issues, challenges that we come across while managing these patients. And of course, 4-5 years back, lung transplantation was a nightmare in India. It was almost non-existent. To welcome our panelists, so we have a wonderful transplant pulmonologist. Let me welcome Dr. Apar Jindal. When we approached him, he said immediately, yes. Dr. Apar is very good friend of mine, and from the very beginning, he's a huge supporter of CCI. Currently, he is the director of transplant program in global hospitals, Chennai, and global group of hospitals, Chennai, Hyderabad, Bangalore, and Mumbai as well. Welcome, Dr. Apar. And if I want to say, the person whom I know most for the long duration is Dr. Richa Gupta. Welcome, Dr. Richa Gupta. Okay, yeah. She is currently heading the prestigious Institute of India, Premier Institute of India, CMC Vellore. She is heading the Department of Pulmonology there. Absolutely great academician to have today. Welcome, Dr. Richa.
Thank you.
Ankit Bhai. Ankit Bhai is a great friend of mine from the very, very early days of CCI. He's one of the core member of CCI. And welcome, Dr. Ankit. Currently, he's a senior consultant in both pulmonary and critical care, working with Fortis Hospital, Jaipur.
Yes. Thank you.
And Dr. Kasi, good friend of mine. Okay, hails from Vijay, pediatric pulmonologist. And he has good experience with few cases of cystic fibrosis. Welcome, Dr. Kasi.
Thank you, sir.
And,
good evening.
Dr. Stuti, another good friend of mine. She is currently pursuing a DM program, and she has completed her fellowship in lung transplant. And welcome, Dr. Stuti.
Thank you so much, sir. Thank you.
Last and most important is Dr. Jyoti Bajpai from Lucknow. She is currently working as assistant professor, Department of Respiratory Medicine, at King George's Medical University, Lucknow. Welcome, Dr. Jyoti.
Thank you, sir.
So, without wasting much time, so today the flow will be like this. First, I invite Dr. Stuti to talk on radiological manifestation and overall view of cystic fibrosis, and then followed by Dr. Kasi will share his thoughts. And my dear CCI audience, please, post your inputs and questions, whatever you have doubts. I know this is a very rare problem. I must say that we are missing many cases in India. There is a theory called red car theory. The red car theory is nothing but if I ask you anyone from during past 1 hour of your travel in a city, how many red cars you have come across? No one can really say that how many cars, the red cars he has come across. But we would have gone through many red cars while traveling in a city or wherever. So it is similarly cystic fibrosis. We would have come across so many cases in our practice. It is sheer lack of awareness. We would have missed so many cases. This webinar is an idea to increase the awareness and to increase the early identification of cystic fibrosis patient. So please post your questions so that we can discuss in the panel discussion. Over to Dr. Stuti.
Everyone, thank you, Dr. Vijay, sir, for this kind introduction. I would also like to express my humble gratitude to Dr. N.H. Krishna, sir, and CCI for giving me this unique platform to express my thoughts about this procedure and providing me this opportunity to be on the same platform as all the esteemed guests. So, I'll be covering the pathophysiology of cystic fibrosis. Okay, so first of all, it is a genetic disease which is autosomal recessive. More than 2000 CFTR mutations have been reported. However, we need to understand that there are less than 200 of these produce a disease. And most of the cystic fibrosis is caused by 5 main variants, which account for more than 2/3 of all the cases. In this, the most common is delta F508 deletion, which is 66%, followed by other 4 mutations that we can see. So, how do we know which mutations are important? So, on the basis of genomic sequences, we have classified these variants on the basis of clinical consequences. So, there may be a loss of function variants, which causes cystic fibrosis when paired together. There might be variants that might be having residual CFTR function and presenting with milder phenotypes. There might be variants which have no clinical consequences. We might only be picking up during clinical studies and genetic studies. And there are variants which have unproven or uncertain clinical significance. So first, let us see what is the role of CFTR ion conductance channel. So basically, it is at the apical side of the membrane here, and it allows the transfer of chloride and bicarbonate ion to the outside, which helps in formation of mucus layer and provides the, because of the chloride and bicarbonate, there is the water content which comes into the mucus layer, which makes it easier for the cilia to transport the mucus. Now, there's first of all, the mRNA is transcribed into the nucleus. So this is one step, normal synthesis. Then it is sent to endoplasmic reticulum, from where, after processing, it goes to Golgi body, and from there it is not trafficked to the apical membrane. Now, mutations can happen at any of these steps, which can lead to various clinical heterogeneous manifestation depending on where the step has been altered. So based on that, 7 classes. So class 1 is synthesis defect. What happens in class 1 is there is no production only. And so there is no CFTR ion which has been produced, ion channel which has been produced. Then second is the processing defect. In this, there is a normal processing. However, there is a processing defect. When has gone to endoplasmic reticulum, it has not been packaged properly. Then Class 3 is gating. From the Golgi body, the membrane, the ion channel has to come at the apical surface. And from there, it gets inserted, and this is called gating. So there may be issues with that. Class 4 is we have the ion channel, but it is not working properly. So it is a conductance issue. Class 5 is the amount of protein that is produced is very less. In class 6, the protein that is produced is an adequate amount, but it is not adequate. So when it reaches the surface, it is not very stable. And there's another class 7, which is at time due to incorrect processing. So what happens? There's decreased chloride and bicarbonate conductance across the ion channel, and there is loss of inhibition of epithelium sodium channel. So both these things causes the absorption of airway surface fluid. So the mucus is very dehydrated and it cannot be propelled upward by the cilia. And this bicarbonate deficiency also affects the bacterial killing. So how does this affect? So there are two hypotheses. I've taken up this beautiful picture from Journal of Internal Medicine. So there is a low volume hypothesis in which, due to excessive activity of ENaC, there is airway surface liquid depletion. Okay, so there's too much sodium which is pumped out, and this causes dehydration of mucus. And so what happens? There's CFTR dysfunction. It causes dehydrated airway surface liquid, which causes impaired mucociliary clearance. This leads to recurrent bacterial infection, and then we have this vicious cycle of neutrophilic inflammation and tissue destruction, which leads to irreversible dilation of airways, bronchiectasis. Over time, these insults keep on accumulating to cause lung failure and respiratory failure. Now, as we had seen that we have basically classified them into classes, but a single mutation can be classified into multiple molecular defects. Like the most common delta F508 deletion is also classified as a class 2 defect because it causes defective protein folding. It will also reduce channel conductance, which is class 4, and it causes increased cell surface turnover, which is class 6. So this is the summarized how we get respiratory failures and complications in cystic fibrosis. There's abnormal mucus, which is predisposing to chronic infections. Any new infection episode causes a pulmonary exacerbation. The body's immune system kicks in. There's an inflammatory response, which causes increased airflow obstruction, which due to continuous inflammatory process leads to bronchiectasis. Over time, this can cause significant lung damage, and patients can land up with complications such as pneumothorax and hemoptysis as well, and respiratory failure. So now coming to the radiology part. Radiology part is predominantly airway involvement. There will be bronchiectasis, which is generally symmetric, upper lobe dependent, central bronchiectasis with bronchial wall thickening, and you might see luminal impaction in it. And the right lobe is often involved first, and it is involved the most severely. There may be varicose or cystic bronchiectasis, and in the later stage, they may be finding of small airway disease. So I have taken this from web. I did not have any clinical picture of my own patient. We did not take the pic of the CT scan. So this has been taken from web. So as you can see, multiple dilated bronchus can be appreciated predominantly in the upper lobe. So this was all from my side. I'll be handing over the mic to Dr. Kashi for further talk on management. Thank you so much, sir.
Good evening, everyone. I'm Dr. Kasi Bandaru, a pediatric pulmonologist and intensivist care hospital from Vishakapatnam. I really thanks to CCI for giving me opportunity to speak about cystic fibrosis. I sincerely thanks Dr. Vijay Kumar for giving opportunity to talk a clinical overview and participation as a panelist in cystic fibrosis. And I thank Dr. Atul Gupta, Dr. Stuti Gupta madam for his excellent presentation over for a pathophysiology of cystic fibrosis. So with that, today just I'll give overall view of a cystic fibrosis and which will open for a further discussion during the webinar. So starting with the age-related presentation of cystic fibrosis, it can present from the antenatal age to the adult age, older age. So antenatal age presentation can be seen like a echogenic bowel sounds on ultrasound, and coronary venal sampling or amniocentesis will be positive in a high-risk family members. And a less common presentation can be perforated meconium ileus. Next, in neonatal presentation, diagnosis is mainly made on the newborn screening and meconium ileus, and there will be gut atresia obstruction, and there will be obstructive jaundice and soluble vitamin D deficiencies. And infant and younger children, there will be recurrent respiratory tract infections and failure to thrive are the two main symptoms, and there will be less presentation of a rectal prolapse, anemia, edema, and hypoproteinemia. Whereas in older children and adults usually presents with a recurrent respiratory symptoms, which can be labeled as an asthmatic, along with a clubbing, with a sinopulmonary like nasal polyps or sinusitis. Whereas in adults, it can present with adult cystic fibrosis can be presented with a related comorbidities like cirrhosis and diabetes, etc. And with a less common presentation of a pancreatitis, malabsorption, dehydration, and electrolyte disturbances. These are the just overall view for a how a cystic fibrosis is present from the antenatal stage to the adult presentation. Next comes to the diagnosis of a cystic fibrosis. Diagnosis of cystic fibrosis is mainly by presence of one or more organ system involvement with a diagnostic laboratory positive. One or more characteristic phenotype features consisting in cystic fibrosis are chronic sinopulmonary disease, gastrointestinal or nutritional abnormalities, salt losing syndromes, male urogenital abnormalities resulting in obstructive azoospermia, or a history of cystic fibrosis in a sibling, or a positive newborn screening test result, along with a increased sweat chloride concentration, or identification of a CF mutations, or demonstration of a abnormal nasal epithelium on the transport. These are the clinical diagnostic criteria for a cystic fibrosis. These will be confirmed with the laboratory confirmation cystic fibrosis is. Till now, the gold standard for cystic fibrosis is a sweat chloride test since many years, which is a sensitivity almost 96% and the specificity of 93%, where there will be analyzing of a sweat chloride levels, which is done by either a macroduct or a nanoduct or a collection of a sweat chloride by other levels like indigenous levels, where the analysis of sweat chloride will be done, whereas a positive can be taken as 60 millimole per liter, intermediate is 40 to 60, and normal is less than 40. So intermediate again 40 to 60 has to be confirmed by the mutation analysis, because in a almost like 60 to 45% of intermediate can present in the later stage like a diagnosed cystic fibrosis. So there are so many retrograde studies which says that intermediate 40 to 60 values has to be followed for the next clinical present of cystic fibrosis, which should not be missed. Then mutation analysis for cystic fibrosis, there are more than 2,000 mutations are there, where 2 mutations almost supports a cystic fibrosis diagnosis, and transepithelial nasal potential difference helps in a rare causes. These are the tests to be done in the children and adults, whereas coming to the newborn, where there is a done by immunoreactive trypsinogen, activity will be increased. Again, the positive test sample will be confirmed by CFTR gene mutation or sweat testing. Antenatal testing also to be done for cystic fibrosis in the carrier mother, either direct mutation analysis on fetal cells, coronary venous sampling, or amniocentesis. Once the diagnosis is confirmed, other family members and siblings also to be screened for the disease. Management. Here the management plays a very big role. The management, especially lung disease, extra-pulmonary disease, and there should be handling or management of proper psychological issues. So cystic fibrosis predominantly lung presentations. The disease stage, pulmonary status, aim, and management. The disease stage can be early, intermediate, or end stage with the complications. So in early, the pulmonary status is in the pre-infection. Your aim should be to give a good mucosal clearance to prevent infection and to maintain a good lung functions. So the mucosal clearance can be either in the airway clearance techniques, which I'll be discussing later, and second thing is using of a mucolytics like hypertonic saline or dorsanase or mannitol, and prevent infections. Whenever the child had an infection, you have to treat the appropriate organism with appropriate antibiotics and influenza vaccine, and you should maintain a good lung function by regular monitoring the child lung functions. Next is the intermediate stage where the child already have a chronic usual infection with either Pseudomonas aeruginosa, Staphylococcus aureus as influenza. Here your aim should be suppress the ongoing infection. Either against, you should give an antibiotics against these three organisms, and you have to reduce the inflammation by giving anti-inflammatories like either azithromycin or ibuprofen. And the last stage is the end stage with a complication where the child will be present or adult will be present with the severe hemostasis, pneumothorax, or respiratory failure. The aim should be prevent bleeding from maybe fatal. Can be done like management can be done like a bronchial arterial embolization, drainage of the lungs, or lung or heart transplantation, or both lung and heart transplantation. So effective airway clearance is a critical component of a cystic fibrosis along with the pharmacotherapy. The methods can be either airway clearance techniques, postural drainage as percussion, active soil of breathing techniques, autogenic drainage, positive expiratory pressure, oscillating positive expiratory pressure, and high frequency chest compression, that is a West. These are the extra-pulmonary manifestation which is to be managed, especially mainly pancreas, which can be pancreatic insufficiency or pancreatitis, and to be managed with a pancreatic enzyme replacement therapy and a fat-soluble vitamin supplementation. The other extra-pulmonary manifestations are like esophagus, gastroesophageal reflux disease, where you to be managed with a prokinetic plus antacids, small bowel, meconium ileus, celiac disease, and Crohn's as per the clinical presentation. Colon can be presented with a constipation. Dietary management is a dietary advice and laxatives. Rectum is a rectal polyps, usually resolves by supplementation of pancreatic enzymes, and the liver is fatty liver or cirrhosis, ursodeoxyriasis, and the last option is a transplantation. And these are the latest or emergency therapies in cystic fibrosis, that is a CFTR modulator therapies. So where that therapies will be targeted again the defective CFTR gene, that is a potential like avocaftor or characters like a tazocaftor or elexacaftor. So the triple drug combination now available in India in the form of a tricaftor, an important from an Argentina, that is a elacaftor, tazocaftor, and ivacaftor. This is a triple combination which is approved for the age 2 years and older. There are many studies showing the efficacy of a triple drug combination, almost 95% on the CFTR gene mutations, and the long-term safety and efficacy data to be available. In summary, cystic fibrosis is a commonest inherited disease with the incidence of 1 in 2,500 newborns in the UK, whereas in Indian population it is 1 in 43,322, 1 in 1,323. Screening programs for the newborns to be implemented because of earlier diagnosis and multidisciplinary care leads to greater potential to live longer. The cornerstone of a management are a proactive treatment of airway inflammation, encouragement of a good nutrition, and active lifestyle. New approaches such as a gene or small molecule based treatments have a potential to halt the disease progression. Thanking you.
That was a very, very lucid talks from both Dr. Kasi and then Dr. Stuti. Really appreciate for those talks. So, having listened to those two talks, my question is to Dr. Richa and Jyoti. So, Dr. Richa, okay, we do come across bronchiectasis cases day in and day out. It is not at all an uncommon scenario in the pulmonologist practice. See, where should we think of including the differential of cystic fibrosis in day-to-day practice.
Right. So, thanks, Vijay, for having me on this panel discussion. Now, as you already said, this is pretty rare disease. In our department, we have around 6 living patients who are under follow-up with us, and one 26-year-old died about 5 years back. So, if you talk about, yes, we do see lots of bronchiectasis, which could be related to post-infective causes, which is the most common cause of bronchiectasis in our country, or the cartigenars, or the PCDs, and primary ciliary dyskinesias, and also Dr. Kasi has wonderfully put it up, the clinical symptoms of the patients. How do we suspect is probably, if I would take it in that way, cystic fibrotic patients usually will be more symptomatic from their younger age onwards, whereas post-infective, again, if you're looking at tuberculosis, it will be more, may they not be very young patients. That is one thing. Other than that, because I believe a detailed clinical history, including a family history, will make a way to suspect the diagnosis of cystic fibrosis, as it has other systemic presentations also. So most of the time, the patients or the family may, for that matter, family may be worried about the child having recurrent respiratory tract infection, but at the same time, the child may have diarrheas, which may be taken as not into consideration. So those would be some of the pointers towards where we would look like. Again, the very classical sign, no, when the mother kisses the child, it feels salty. That is a very classical sign. If it is something that it should immediately raise the bar, the eyebrows, that we have to look for something else. Then failure to thrive, lots of deficiencies in children. The other thing is the child is not growing according to her age, despite having good appetite. So that is again one, pointer towards where we should look at, because there may be malabsorptions which we are not dealing with it. And one thing important when we see in our pulmonology practice is asthma. It is very, very common disease, and any person who comes with breathing difficulty, younger patient, we say it is, it's labeled as asthma. But an asthmatic patient, young asthmatic patient with proper treatment, if not improving, that would be a key that you should look for the other diagnosis. And cystic fibrosis forms one of the differential diagnoses in almost around 14 to 15% of these patients. So I think that is from my side. So look for the other presentations. Do not, even if they are mild symptoms, they should not be just rigged off.
We should keep a probably very, very low threshold to suspect at least.
Yes.
Okay.
Yes.
Right. So, Jyoti ji, can you please, add your thoughts here?
Yeah, thank you, Dr. Vijay, for giving this opportunity to me. So, as per the ma'am said, it is rightly said, when we suspect in the case of bronchiectasis, rule out cystic fibrosis. It is very important. So, as per the Indian guidelines, we don't have any data, but at the ERS 2017 guideline, they have recommended any child who is coming with bronchiectasis, we have to rule out cystic fibrosis in those patients. For adult patient, those patients who have bronchiectasis, the classical presentation of the bilateral upper lobe heterogeneous and the diffuse involvement of bronchiectasis, as well as patient belongs to younger age group, less than 40 years of age, and there is a nasal polyp, history of nasal polyp, chronic sinusitis, and male infertility. And in malnutrition, weight loss, they are not gaining weight, or there is a history of weight loss, and as well as very important, there is a family history. So we took all these points in consideration for excluding cystic fibrosis. So first of all, bronchiectasis, as well as along any one of these factors, if patient is having, we have to look for cystic fibrosis in our country also, because Embark India registry has been done in 2015 to 17, and they have written less than 1% cases of there is a primary ciliary dyskinesia and other abnormality. They have not written properly how much prevalence of cystic fibrosis in our country. So I think there is a high time, and this is a rise time, and this webinar is going to insight to all of us. We have to look for in bronchiectasis patient in adult population also, those who are coming with these are features like sinusitis, polyp and all I have discussed and ma'am already discussed, to exclude cystic fibrosis in our country. So this is from my side.
Yeah, absolutely. Brilliantly placed. So from Dr. Richa, okay, there is a, if there is a failure to thrive and there is a multi-system involvement, particularly like respiratory involvement along with the gastrointestinal involvement, then in presence of recurrent symptoms in very early childhood, which is not responding to the conventional management, please keep a low threshold to investigate for cystic fibrosis. And from Bajpai, so if we are dealing with in children, so definitely bronchiectasis in early childhood, cystic fibrosis must be ruled out. And in adults, if there is a nasal polyposis and then male infertility, probably we should, in combination with respiratory symptoms and failure to thrive, it is very, very important to rule out cystic fibrosis in our clinical picture. Coming to, let me invite Dr. Apar Jindal. So it is said, okay, various literatures that was published from India as well, I have gone through, which says that cystic fibrosis was almost non-existent in India to begin with. And as per the literatures, probably a couple of decades back. But recent trend shows there is more number of cases getting published. Your comments, Dr. Apar.
Apar, you are muted. Apar, you are muted.
Thank you, Richa, for pointing that out. See, agreed, Vijay, there's not a lot of literature that has come out from our country. I think there is no large-scale study, looking at cases from throughout the country. There are few sporadic reports from North India, few reports from Chennai, from Vellore. Centers which are actively looking and screening for cystic fibrosis are the ones that have published small data. If we look at the availability of data, which is on an international level also, the difference is astounding. Just to quote a little bit of numbers over here, if we look at the prevalence in the United States, where it is 1 in every, say, 3,500, or in UK, where it is 1 in 10,000 children, the prevalence in India is stated to be 1 in 250,000 children. Now, there was a small study which was done in California, looking at Indians who have migrated to California, and children from these families were studied. Here, the numbers were much higher, especially Indians who had married with people from other races, especially from the Black races or from the Mexican, Latin American races. There, they found that the number, what we normally thought was to be 1 in 200,000, came down to 1 in 40,000, which is a huge difference. So I think there is a lot of role. The other thing, when we looked at genotyping studies, what we've seen that most of the Indian children who were found and who were genotyped had novel mutations. The typical Delta 508 mutation was present, but the varieties of the Delta 508 mutation, which is found in the Indian children, were different from those found commonly in the Ashkenazi Jews or those found commonly from the American studies. So I think there is a lot of gene disparity, or there is a lot of mutational disparity, which is actually protecting the Indian race as such from this disease. But yes, of course, intermingling, consanguinities, these are two major reasons why we may be seeing, much more of this disease coming up in our population.
I totally agree with you, Dr. Apar. Even there are similar studies which, as you have quoted, there is study from Canada, there is study from Northern Europe, which has clearly mentioned those who have migrated from India to other parts of the world. So there the incidence is particularly not only India, across from Asian population, which was said that it was less existent. Okay, now it is being increasingly diagnosed in other parts of the world. Totally agree with you. And coming to Dr. Ankit, okay, let me ask you, what is the importance of newborn screening for early diagnosis of cystic fibrosis? and what's the current state in India? And then subsequent question will be to Dr. Kasi. So, do we really need to do the newborn screening program in all the children?
Thank you, CCI and Dr. Vijay, for giving the opportunity. Yes, as we learned in the presentations also, neonatal screening has a very vital role in assessment of the disease. So if we do an early assessment, maybe we will be detecting the disease early, even in the asymptomatic phase, or maybe a very mild symptomatic form. So how it could help us? Maybe decrease the morbidity, maybe delay the mortality, or it may help in possibly improving the physical development of the patient also. There could be slow lung deterioration. We could identify early infection. We can learn the ways to treat infections, and we can give a good, reasonable nutritional supports to those group of patient also, if it is detected early. The main problem particularly arises when they are detected late, in the late childhood or the adulthood. There is already advanced disease. So there are ways in the Western countries. Yes, they are performed. One is, as Dr. Kasi has just discussed with us, immunoreactive trypsinogen IRT level from the blood spot. This could be detected. It is raised for few weeks to few months. So it is followed by the DNA testing of the CFTR variants. So it can done in both the way. First, the IRT could be detected. If it is positive, then if the patient can go for the DNA testing, or again, the IRT could be repeated after 2 weeks interval. And then it is followed by the DNA testing. Again, sweat chloride test is important after detecting these two stuffs. Regarding the IRT availability in India, I'm not sure about it. But yes, few centers have developed DNA testings for CFTR mutations.
Yeah. Thank you, Ankit. Dr. Kasi, what is your thoughts?
Sir, presently there is no proper neonatal screening test, but they are including in the packages, like some of the genetic system they are doing in a Bio7, so which is covering cystic fibrosis screening, sir, by immunoreactive trypsinogenesis. But presently there is no alone or screening method to detect cystic fibrosis, but they should be included in the national programs or other screening programs where we can know the magnitude of the problem and we can detect the disease earlier.
So do you agree that, do you think as a practicing pediatric pulmonologist, a country like this with very, very less incidence of cases as per the reports, do you still feel that neonatal screening is mandatory?
Yes, sir. Neonatal, sir, we have very less data because there is no many studies has done here. So at least to know the data, we should, once we include the screening, we can know the magnitude of the disease, then we can say whether it's a significance or not. And
Okay.
second thing is, compared to the Western diseases, Indian presentation is at the age of almost 10 years, where we are missing at the very earlier age, where almost the child is presenting at the late stage, where resulting in the almost death of the child. So early newborn screening will help the child to have a better life, better prognosis, sir.
So, my dear audience, Dr. Kasi is watching for a mandatory neonatal screening program so that there is no delay in diagnosis of this disease. Because once the disease, for that matter, any disease, if we diagnose at the earliest possible time, the chance of treating better these patients, and then the chance of we can delay the onset of the complications, particularly bronchiectatic related complications, and so that we can definitely make the quality of life of these children better. Thank you, Dr. Kasi. So,
One more thing, sir, can I?
Yeah, please.
Yeah. So most of the children presenting at 8 to 10 years, that is a different presentation from the West, is especially a malnutrition, where if you screen an earlier age, we can give a better nutrition and the prognosis will be the better. So here delay screening is resulting in the a big issue in the malnutrition. Again, that leads to all the consequences of end lung diseases.
I'll definitely come there regarding malnutrition. we have plenty of points to discuss regarding malnutrition as well. So can I ask Dr. Stuti Gupta to throw some light on pilocarpine iontophoresis, which is an indigenous method to diagnose cystic fibrosis?
Thank you, sir, for giving me this opportunity to be on this stage. And especially thank you to Dr. CCI and Dr. Anish Krishna, sir. So
honestly, it was a good talk that you have delivered. Really appreciate for that. Right. And you have taken the challenge in last couple of days. Thank you.
Thank you, sir. So pilocarpine iontophoresis, basically, see, whenever we are talking about the newborn screening, we have either immunoreactive trypsinogen test, and then the next step would be sweat chloride testing. So how to do the sweat chloride testing? Sweat chloride testing, first of all, you need to collect the sweat, and the test to measure that amount of fluoride, we need at least, most of the guidelines say we need at least 100 milligram of sweat. So it's impossible to make a patient sweat so much. So pilocarpine iontophoresis is basically, it is a cholinergic drug. So what we are doing is we are putting 2 electrodes on the patient, and it gives a very small amount of current. It is nothing to be scary. It's like small needle prick. The patient hardly feels, and it incorporates the drug pilocarpine. And there is another gauze which is taped to the skin, which keeps on, after giving the pilocarpine small amount of current. That's why iontophoresis, for 5 minutes the skin keeps on secreting the sweat which is being collected into that gauze, and that's then that gauze is collected, and by colorimetric method then it is sent to a biochemistry lab and they determine the chloride level. So that is the whole basis of pilocarpine test, iontophoresis test.
Thank you. And Dr. Richa, can you please add the role of serum immunoreactive trypsinogen in diagnosis and then screening of cystic fibrosis?
Right. So immunoreactive trypsinogen, actually this test is being used as a screening test only, not for the diagnosis, first of all. And that is as a test for the newborn screening. So it has been universal newborn testing is being implied in USA from 2010 onwards. We know that trypsinogen is secreted by pancreas. So on the second or third day of the newborn baby, you prick the heel and you have 2 or 3 drops and you check it as like kind of a test. So usually if the trypsinogen levels are high, that may suggest that this patient may have cystic fibrosis. Now, again, it is just a screening test. It is not diagnostic. So which also means that it is a sensitive test, but it is not specific enough to make a diagnosis of cystic fibrosis. There may be other reasons where this IRT may be raised, as in premature baby, or if the labor is very stressful, then also this child, this can be positive. So we have to be careful. If positive, then you go ahead and do the sweat chloride or CFTR gene mutation to look for confirmation of the diagnosis.
So to make it more simple, it is like a D-dimer in evaluation of CT pulmonary embolism. Maybe raised. Okay, may give us a clue.
More sensitive, I would say.
Right.
Yeah.
So, in presence of our clinical features and absence of elevated sweat chloride, that is also a scenario where we rarely I have gone through some publications in the literature. And can you please throw some light on how and what to interpret such a kind of borderline sweat chloride levels?
Is it for me?
Yeah, you, and I'll also take inputs from Ankit as well. Please go.
All right. Sure. So it depends on what kind of mutation CFTR gene it is having, and that is what will cause your sweat chloride positive. So Stuti has already shown, you have more than 2,000
mutations,
but only less than 200 in India, and more than around 750 mutations in US has been implicated to cause the disease. So still, the patient may be cystic fibrosis, but the gene which is mutated, the exon which is mutated, may not cause the sweat chloride test to be positive. So in that scenario, if clinically you are very much suspecting that everything is fitting, but the sweat chloride is negative or kind of in between indeterminate, then probably the next step is for the confirmation with the CFTR gene mutation test you have to do. That would be the confirmatory test.
We don't have all the mutation analysis as well available. Probably we are testing only very few mutations as of now in India. And can you please add your inputs here?
It's always difficult to analysis. Sweat test chloride is a useful test to suspect cystic fibrosis. But there are certain things we can go ahead with certain investigations, because these patients has certain other manifestations also, which include the electrolyte levels like sodium, potassium chloride. You can check for the stool if it is particularly child for fat globules. And again, the sputum and respiratory cultures for Pseudomonas. It will just give you a clinical suspicion. Though, right. So patient may have hypochloremia, hyponatremia, hypokalemia, metabolic alkalosis. There could be fat globules in the stool. And particularly if patient have some kind of infection, particularly Pseudomonas, right. It can again give you a clinical suspicion, but again, it has to be confirmed. And for that, you need a sweat chloride test and other further genetic analysis.
Right. Ankit, there is a question particular. Yeah, please.
Yeah, if I can just come in, see the problem with sweat chloride is the way that the test is done at most of the centers, even at the centers of excellence. I've worked at Sacramento, where we see a very large number of cystic fibrosis patients. The performing of the test, the collection of the sweat in the adequate the tissues is actually what is the most important step is doing the test. Most of the time, we do not get enough sweat from these children to be actually able to assess that how much is the chloride level in the sweat in this.
Right.
You need at least about 15 to 30 milligrams of dry weight of sweat in the blotting papers that we use to collect the sweat to actually test it. Unless you have that, typically what we've seen, and I discussed this with Dr. Venugopal as well, who does a lot of cystic fibrosis work here in Chennai. Most of the time when we do this, the typical levels that are collected are either 5 to somewhere ranging between 12 milligrams, which is not enough to do the sweat chloride test. So unless you have enough quantity of sweat, you will not get a meaningful result. So as you said, in the presence of clinical features, in the presence of a strong clinical suspicion, a negative sweat chloride test, I don't think holds good amount of water. Moving on to genetic mutations, if we really want to confirm it, or labeling a patient as cystic fibrosis, depending upon the clinical conditions, should be good enough.
But vis-a-vis, we also have a problem of, we are not testing all mutations. We are testing only very few
mutations. For all mutations. There are more than 2,000 known mutations. How many mutations can we do? Unless we go for a complete genomic analysis, where also...
Essentially, 0 down to, so clinical presentation, high suspicion, when the features are there, do a sweat chloride test, and if it is even negative, for confirmation, if you have a high suspicion, confirmation genomic analysis, and then diagnose the case, right?
Absolutely, and I think that is going to be the major hindrance in establishing this as a national program or national policy in our country. We don't have the typical mutations, as you've mentioned, that we see. The Indian population has reported whatever cases we have seen have reported novel mutations. It has, what we have seen in the publications is a lot of rare mutations. So using something which is not typical, it is very difficult to establish it as a, national program. And the social, the economic, the logistic aspects of it, that would be just nightmarish.
True. I totally agree with you, Apar. Can I pitch in? Can I ask Dr. Kasi to pitch in? So that, can you please elaborate, Dr. Kasi, how this sweat chloride test is being performed? We are discussing about the results of sweat chloride, but how it is actually performed.
Sir, before going to that one, there are 3 scenarios in India, sir.
Yeah.
So one is many of the centers are not having this sweat chloride analysis, sir. In that situation, we should totally go on the basis of the clinical features. If you suspect the clinical features, start the treatment. Whenever the diagnosis of sweat chloride analysis are available, you shift to the center. That is one thing. Second thing is, sir, here the major issue in here is what a cost. Because there is a what they called as a indigenous method. It is very cumbersome method where you have to spend almost 1 to 2 hours in doing the test, and children are notorious. We can't even catch the children. Actually, it is easy to say because there will be a lot of side effects, burns and all. But here is compared to other things, there is some other systems there, sir, like a macro duct and a nano duct, which is easily collecting the sweat. So here what I'm saying is, if you suspect, if you don't have a diagnostics, follow the child, start the treatment, and refer the child where you're having a diagnosis. Second thing is coming to the how the sweat is collected. So all the methods are using one method, that is an ionophoresis, sir. You keep the pilocarpine, you generate the sweat from the sweat chloride, sweat glands, and you analyze the sweat. So in sweat especially, we will analyze two things, sir. One is chloride levels and the sodium levels and osmolality. Sodium and osmolality are not reliable, so we need to assess the chloride levels only. So anything chloride levels more than 60 is a diagnosis of cystic fibrosis. It is 40 to 60 is an intermediate, less than 40 is the negative. It's a normal value, sir. So again, how to collect the two systems, sir? One is indigenous method. So you asked me one more question: is it a painful, or what is the cost of it? So indigenous method in India, what they're using, they're charging 1,000 rupees. Whereas coming to the other system like advanced systems, nano duct and macro duct, they're charging around 3,500 to 4,500, sir. Where the systems themselves, they'll collect the sweat, and themselves they analyze the sweat, sir, and they'll give the chloride levels, sir. So this is what
for this, if I want to establish the sweat chloride analysis at my center, how much it would be costing?
Sir, yeah, that's what, sir. It will, sir. If you want to go indigenous method, it is some 10,000 to 20,000, sir.
Oh.
If you
Right.
that is, so you can charge a patient for around 500 to 1,000 rupees. If
Right.
if you don't want to waste a time, and there is a side effects also like burns and all will be there. If you want a sophisticated measures like a nano duct, which is costing around 5.5 lakhs, sir, which will collect the cyst and give the result of conductivity. And there is another more which is costing around 12 lakhs. That is called as a macro duct. It will collect the sweat. It will analyze the chloride levels, sir. So these are the three.
To be honest, okay, we have tried. My colleague, Dr. Samya Rajvi, who is a pediatric pulmonologist, now she has moved to US. She has tried her best to convince our corporate systems to get this macrotech method, but ultimately we failed because they want numbers. Unfortunately, we could not establish that as center. We do refer when we suspect. We do refer to other centers. Right. Coming to thank you, Kasi, for that inputs. And can I ask Dr. Jyoti for this is one such disease. It is very, very okay. Almost we can say that declaring a diagnosis will become a key component to the parents, because we don't have a cure for this disease and it's a lifelong problem, and mortality, morbidity is too much. Dr. Jyoti, can you please enlighten us how in such a scenario and for such a case, can you please tell how you will prepare yourself and then how you prepare the family for declaring the diagnosis?
Thank you, Dr. Vijay, asking this question to me. I think this is a very difficult question to answer it because my experience regarding the cystic fibrosis is very rare. I think 4 or 5 cases I have seen. One is from Dr. Richa ma'am college, CMC Vellore, young patients. So it is very difficult for us and for the patient and family also to declare the diagnosis. First, made a diagnosis is a very difficult thing. Whenever we made a diagnosis, then how to break this diagnosis in front of patients or attendants is really very difficult. But as a physician, as a clinician, we have to explain all the symptoms, what are the symptoms, what are the prognosis, what are the clinical factors, what are the medication is available in India and out of India. We have to explain everything to our patient. And the last, the most important, lung transplant, we have to ask about these things to our patients also. And one thing is very important, genetic counseling. I don't think it is available in India for the cystic fibrosis patient or not, but it is very important for the family or parents also to know other family members might be there suffering, because we know that this is an autosomal recessive disorder, and it was discovered in 1938. Since then we have a long way, but still we are struggling to diagnose and find out the options to how to help our patients. So because there is a no national screening program, there is no national guidelines, it comes under the NORD disease, National Organization of Rare Diseases, but there are a lot of different things we have to face whenever we diagnose these kind of cases. So first of all, I would summarize in 2 or 3 points. We have to explain everything, every aspect of this disease to parents. And what are the second most important thing about the genetic counseling, how to help our family members, their family members, to with those patients who are struggling with the disease. This is from my side.
Dr. Richa, can you please add anything that you feel that can be added here?
Yeah, so since it's a chronic disease, and if the child is affected, the whole family gets affected. So we do it not, it's just one counseling for us. It goes 2 or 3 sessions, and one by one it goes. So it's taking in the pictorial representation and showing that, this is how it is. And having said that it is there, what I always say is that, see, disease is there. We can fight with it, or we can just sit with it. Since it is there, we have to fight with it and lead the normal life. So I think assurance is something where, as a doctor, you build in the confidence with your patient and assure them. That takes lots of worry about it. But then again, as Jyoti has already said, that you need to tell them the details about each and every aspect, even though the child is not having or the patient is not having, but these may be the potential complications. So if there are any warning symptoms or signs or new onset, please report to your doctor. Vaccination and genetic counseling is really, really important. Now, I'm talking about CMC. I'm not sure about how outside it is. It is about 13,000 rupees for the CFTR gene mutation, what they are doing. Now, when you speak to the patients, parents, and you ask them that any sibling or the cousins, it is recessive, it can be there. So we do counsel them about that, but the patient just don't want to do it. One is the fear that if it is found in other person also, what will be the thing? And the second thing is the cost. So most of the time you have to restrict yourself not to order that, but save that money for the treatment of the child. So it's a long-term process, and you need to be, we do give our phone numbers to the patient so that any emergencies or anything are there, they can talk. But particularly to, for cystic fibrosis, their children and parents are worried. So it's not just one-time process. It's an ongoing process where you and the patient and the family builds a relationship with you, and you continue to help them in their difficulties.
So essentially, you are saying that it's a lifelong process.
Yes.
How long the kid is going to survive, no one knows.
Yes.
And being empathetic, being supportive to the family plays a very, very crucial role. Having said this, both of them, they have said very clearly, if feasible, genetic counseling is very, very required, because it's an autosomal recessive disorder. So if both the couple have autosomal recessive component of CFTR gene mutation, the chances that the kids may inherit. So that's why in the family, it is very, very important to check either before marriage, even after marriage, to check whether the chance of siblings may get this disease in the family, to assess that it plays a very, very important for suggesting a genetic counseling. Dr. Kasi, the next question is for you. So as per the Indian literature, 4% of the affected cystic fibrosis children present with pancreatic dysfunction, 3% present with liver abnormalities. Majority of them, they present with respiratory abnormalities. So what after the various clinical, what are the various clinical gastrointestinal presentations of cystic fibrosis? I know we have touched upon, Dr. Richa has briefed in the very beginning itself. And when do you consider in such scenario cystic fibrosis as a possible diagnosis, and what are the various differential diagnoses we should keep in our mind? Dr. Kasi, are you there?
Yeah, I'm there.
Yeah, please.
Hello. Yeah, here the presentation is always like majority of the presentation is might be the lung, but along with that 40 to 50, 30 to 40% can be the extra-pulmonary manifestations. As I told in the initial presentation, sir, as already presented. So major thing is a pancreatic insufficiency, sir. So either that is in the form of a malabsorption, where you can give like a pancreatic enzyme replacement therapy and a fat soluble vitamin deficiencies. And the next manifestation is extra-pulmonary manifestation in the form of esophagus, where you will have a gastroesophageal reflux. You should give an antacid plus a prokinetics. And most of the cystic fibrosis, what we fall, they'll come with a constipation, sir. So majority of them will have a constipation. So due to some dietary problems and all, so you need to give a dietetic advice and a laxatives, and some 10 to 20% of the comes with a fatty liver and a late stages of cirrhosis. So you should give a ursodeoxycholic acid or a transplantation is the last option, sir. So these are the extra pulmonary manifestation a child presented with the cystic fibrosis. In that, majority of the patient presents with or majority of the children presents with a pancreatic insufficiency. We have to give a pancreatic enzyme replacement therapy, sir. So that is extra pulmonary manifestation. Now comes to the differential diagnosis of cystic fibrosis is very important. We have to consider, sir. Remember one thing: all causes of infectious causes secondary to the underlying of a persistent or recurrent pneumonia are the causes of a cystic fibrosis. So whenever you are asking, sir, what are the TDs? See, in India, we are all good clinicians. In abroad, they're all they go with the laboratory things. So that's why in all Indian doctors are respected all over the world. So important thing is all causes of persistent pneumonia, you should think of a DDs. Like what are the causes of persistent pneumonia secondary to the underlying? The first comes to the primary ciliary dyskinesia. Second possibility can be the immunodeficiencies, where similar manifestations like a cystic fibrosis. Third can be the asthma is the biggest challenge to us. But how to differentiate asthma from a cystic fibrosis is in a cystic fibrosis, you will have a failure to thrive with a malabsorption. And the fourth possibility can be a bronchiectasis of any changes and a bronchiolitis. These are the other differential diagnosis of a cystic fibrosis. Remember, again, I'm saying all causes of persistent or recurrent pneumonias are the DDs of cystic fibrosis.
Thank you, Kasi. And quickly, I'll ask Dr. Apar before asking Ankit. So, Dr. Apar, is the pancreatic transplant is also being practiced in India?
Yes, there are a few centers that have started doing pancreatic transplants. I think there are about 3 centers across the country, 1 in Delhi and 2 based out of Chennai, that are actually practicing pancreatic transplants. But pancreatic transplants, as of now, what is being practiced is more towards the diabetic population rather than for using it for cystic fibrosis. Even when we look at the protocol for cystic fibrosis, pancreatic transplant actually features very, very late. Even failure, because most of the children do well with enzyme supplementation, dietary supplementation. So we really don't need to go in for a pancreatic transplant. So the thing called pancreatic failure occurs very, very seldom in these cases.
So it's only exocrine insufficiency which can be replaced with the medications.
Yeah.
The transplant is very, very remote requirement in terms of pancreatic transplantation. Thank you, Apar. So here, Dr. Rabindra Bunia from AP, Vizag is asking us how we do nasal epithelial potential test. Dr. Ankit, can you please pitch in?
So it is also one of the ways to detect cystic fibrosis. In this particular way, basically in this technique, what it is seen, there is a difference between the CFTR, that is the cystic fibrosis transmembrane conductance regulator, and the epithelial sodium channel functions are monitored. And how they are monitored? By the change in the voltage across the nasal epithelium, because you perfuse certain solutions And after perfusion of that solution, you measure the voltage across that epithelium, and by that you can detect. So how it is measured? It is measured between the potential difference between the subcutaneous compartment and the airway epithelium in the nostril by utilizing a catheter which is contact with the inferior nasal turbinate.
Okay. Okay.
And that particular solution, if we consider, it consists of around amyloid solutions and isoproterenol solutions, and basically they signal the cyclic AMP, which is there required for CFTR. So
Right.
basically, this is an important concept to establish the hydration of the airway liquid of respiratory epithelium.
Right.
So this is the way it is being measured, and this is also an assessment tool for cystic fibrosis.
Thank you, Ankit. Thank you. Here, Dr. Jagruti Sangvi from Maharashtra asking, do you need a F508 mutation to be positive for Trikafta to work? So anyone, can you please take this question? Apar?
See, I think very good question. So, one thing that I'd like to say upfront is these medicines, the gene therapy, whether we are looking at characters or whether we are looking at potentiators, these have just revolutionized the treatment of cystic fibrosis. I remember early 2000s, most of these patients would survive only in their 30s. And now we are seeing patients with cystic fibrosis surviving to the 6th decade of life as well. And that is all, due respect to these gene therapies which are available. So let's, if you just give me 2 minutes, I think Trikafta, what this is a combination of 3 drugs. So basically it has ivacaftor, which is a drug that increases the channel, the chloride channel transport across the channel, chloride transport. Plus, it has 2 other drugs, which is tezacaftor and elexacaftor. Now, these 2 drugs, they potentiate or they increase the appearance of the channel on the membranes. So given a combination of these 2, definitely helps most of the patients. So we have a drug which is increasing the presence of the channels, increasing the number of channels on the cell membrane. Plus we have a drug which increases the chloride channel, the chloride ion transport across these channels. Now, the difference between these drugs is whether we are looking at a homozygous mutation or whether we are looking at novel mutations or rare mutations. If yes, the patient has a homozygous mutation, then the drug therapy has to be started much earlier, maybe even at 4 months, 5 months, 6 months of age. And for that reason, I think ivacaftor is the drug which can be started at around 4 to 5 months of age. When we look at the other drugs, whether it is lumacaftor or tezacaftor, most of these drugs can be given only after 1 year. Tezacaftor very specifically and elexacaftor after 12 years of age. So Trikafta will come into picture only when your patient is about 10 to 12 years of age, not before that. Earlier to that, you have to start with ivacaftor, move on to a combination of either ivacaftor and lumacaftor at the end of about a year, or a combination of ivacaftor and tezacaftor at about 5 to 6 years of age. And when these drugs do not work, that is the time when you will have presentations of respiratory failure more than presentations of GI issues. And these are the patients who then proceed towards a lung transplant.
Right. So, very well said. But what is most important is these drugs available in India?
So, Trikafta has been imported for some patients on a case-to-case basis, but horribly expensive. I think only a very few number of patients can actually, afford these drugs. These drugs are, I think, as Kasi had mentioned, either you have to import them from Belgium or you have to import them from Germany. These are not readily available, and access to them is again an issue in that country.
So, as Dr. Baj, yeah, please, Kasi, please go ahead.
So you gave a difficult task, sir. So last 10 days, and we're inquiring. Cystic fibrosis is answered a difficult task. So last 10 days, I'm inquiring about the drugs, sir. So whether we can import it. So you asked me whether importation to the India is there or not. So I had almost 10 days, I'm inquiring. The thing is, sir, there is no importance in the India, it seems, sir. But If you want the drug to use, you should go to UK or US, where every year it will cost around 6 crores, it seems, sir. And it should cover under
much? 6 crores.
6 crores per annum.
Okay.
It should cover under insurance, it seems, sir. These are the practical difficulties in India, sir, for importing a drug.
I was told as the Apar, when I was inquiring about this, there were few patients who could procure it to India, and then there is separate central government for the past, I think, 2 years has exempted these drugs. The taxation policy, through taxation, they are not charging any import taxes for these drugs. So
I think very few of the patients that I know, courtesy Dr. Venugopal, 3 patients to be more precise. These 3 patients had been worked up, children had been worked up for transplant at our unit. All these 3 had been enrolled in clinical trials in US, and the drug was supplied to them on compassionate grounds. So I don't know of any patient in India who has actually bought this drug.
Okay. Right. See, Dr. Jagruti is sharing a clinical scenario. Let me read it out, Dr. Apar. So, I have a 8-year girl with cystic fibrosis diagnosed at the age of 10 to 11 months age. She has a double heterozygate mutation, not a F508. She now has bronchiectasis, recurrent respiratory infections, clubbing, borderline hypoxia. When does she come eligible for a lung transplant? What's the indication for the same? I want to know when and whether she is eligible for a transplant or not. Please comment. And she is also continuing. No, that's it. Please. So, Dr. Jagruti Sangvi, thank you. Really appreciate for participating in this discussion. Okay, thanks for your question. Apar will take your question.
So I think, Vijay, that's a very important question to address. So children who've already developed respiratory failure, here we have a baby. And of course, now I'm not going to be talking about doing a PFT, doing a 6-minute walk test and all those things, because we have a child who's only about 10 or 11 months of age. So what are we going to do for these children? Definitely, once bronchiectasis is leading to hypoxemia, requirement of oxygen and recurrent infections, these are children who definitely need a lung transplant. There are 2 types of options which are available for them. Being a pediatric age group, yes, we can also look at living donor transplant, and these are the perfect candidates where a living donor transplant can be done. What living donor transplant entails is taking up lower lobes from 2 either parents or from siblings who are from the same blood group. So a right lower lobe is taken, and that is implanted into each of the hemithoraces. These patients grow with this lung till the age of about 10 to 12 years when they undergo a repeat transplant or a retransplant with an adult lung. The other option is the standard cadaveric donor. In our country, that is very difficult. So in my experience, we've done a transplant as early as 1 year and 2 months. We've done a transplant for a 3-year-old child. We've done a transplant for a 4-year-old child. All of them were international patients. But to look at it, all of them had to wait for about 2 to 2.5 years in our country to get the donor lung, because pediatric donation in our country is almost non-existent. It doesn't happen. Very rarely do we see such young organs being donated. So yes, to look at it from the indication standpoint, let me now segregate it. For a pediatric population, especially for a population under 5 years of age, development of cystic bronchiectasis leading to multiple respiratory infections with more than 1 hospital admission each year and oxygen requirement or hypoxemic respiratory failure. These are the indications that we will look at for lung transplant. Whether it is a homozygous mutation or whether it is a heterozygous mutation, it really makes no difference. Yes, the only difference is that patients with homozygous mutations, where it is a homozygosity on both the alleles, they have a higher chance of recurrence of this disease in the transplanted lung even before the patients hit the age of 14 or 15 years, where they need a retransplant. So the disease severity is higher, and that can affect the transplanted lung. But yes, in the adult age, definitely what we need to take into account, once the patients become adults or more than 14, 15 years of age, then there is a set parameter. we need to look at, an FEV1 of less than 35 to 40%. We need to look at 6-minute walk distance of less than 400 meters. We need to look at other complications that, respiratory failure coming in with acute exacerbations, coming in with multiple bouts of hemoptysis or life-threatening hemoptysis at any point of time, require any admission requiring NIV, infections, recurrent infections with things like Pseudomonas, with
MDR infections, right?
MDR infections. These are all areas where you would refer the patient for a transplant.
You have brought in such a nice concept here, living donor. So, to my knowledge, I'm not an expert in terms of the at least awareness regarding transplants. Okay, although I have worked with at the UT Southwestern Medical Center as an observer. Okay, that was a fantastic place to learn the basics of and advances of transplant. So I'm sure you are graduated from there, right, Apar? Yes.
Yeah.
See, coming to the living donor concept is practiced only in I think Japan, and it was later because of more mortality in the donors, so they have stopped the program. What are your comments?
No, not at all. So Japan and Korea. Now the largest data for living donor is actually out of Korea rather than Japan.
Oh, but it was begun in.
It was began in Japan, which was due to very poor availability of cadaveric donors. So the average age of donors in Japan is 60 years plus, which does not feel, which is not suitable for lung transplantations. Hence, they were the ones who developed protocols for doing living donor transplants, even in adult patients. Forget about, children over there. But overtaken them is the programs established in South Korea. These are the programs from where a lot of data, and now 5 years and 8 years and now even 10-year reports are available, where the survivability of these patients and the morbidities that post-transplant diseases entail is almost equitable to a cadaveric donor transplant. So there's no difference between these transplants. So definitely this is a feasibility in areas where cadaveric donation is low.
Right.
Now, looking at what you said, donor mortality. So this was more of a theoretical concept. Actually speaking, a living donor transplant can have a 300% risk or 300% mortality risk, where you can have death of the recipient and death of 2 donors. But till now, 0 donor mortalities have been reported.
Oh, thank you for that clarity, Dr. Apar. So here, Dr. Suchit from Mumbai is asking us how to eradicate the prolonged bacteria like Pseudomonas, Staphylococcus, even after 2 bronchoscopies and recurrent hospitalization. And he also asking us to throw some light on longer antibiotic rotations. Let me ask Richa first, and then I'll come back to Apar again. Dr. Richa, you're there?
Yeah, very much there. So what we practice in our pediatrics department, and I have only that much knowledge. Routinely, it is not prescribed, but there, if you have that recurrent Pseudomonas coming up in your secretions, then you will require antibiotics. But if there is colonization, then what we give is inhaled antibiotics, mostly tobramycin. Again, it is a little costly, so sometimes we give the cheaper version of gentamicin also. How the patient's affordability is. So that is again the same as it is for adult. The eradication of Pseudomonas, you give 28 days of NEPs, then 28 days of off, and accordingly you repeat the cultures and see. That is one thing. Oral antibiotics, usually in adult patients, adult bronchiectasis are very, very symptomatic. Recurrent infections are there. We give azithromycin, has been found to be pretty safe even as long as for 2 years. So those are the 2 things. And other antibiotics, probably depending on if the culture is showing something which is more specific, then it would.
So basically, you want to say that repeated cultures, and then make sure you give 4 weeks of antibiotic, and then probably give a break, or else if the sputum is still showing culture positivity, probably continue the antibiotic, right?
Yes, that's the inhaled antibiotic.
And
The eradication.
gentamicin can be replaced with tobramycin in your experience.
Yeah, in very small cases, I would say.
No, naturally,
Sir.
each tobramycin is costing somewhere around 1,000 rupees, I believe, right? Each respule. That is pretty much for Indian patients. So, can I ask Dr. Ankit? Ankit, what is when a patient with assume presented with recurrent infections in the background of bronchiectasis, what is your choice of antibiotic and how you will design the empirical antibiotic therapy?
Definitely, it depends upon the microorganism that we isolate, and we can isolate a range of microorganism. In the initial years, definitely staph infection could be there. So definitely some flucloxacins and associated antibiotics will work. But if we have MRSA, then you can't have used linezolid or vancomycin. But if we go into the gram-negative bugs and the notorious bugs and the resistant bugs, MDR bugs, then your choice get limited, particularly sensing Pseudomonas, extended spectrum penicillins along with aminoglycoside would be choice. Yes, nebulized tobramycin is a very good choice now, can be given in the cycled phase to eradicate it. But yes, you can also appreciate other microorganisms, which include Acinetobacter, Burkholderia. So based on the sensitivity patterns, we can always assign antibiotics to it.
Right. Thank you. Thank you, Ankit.
Sir, here I want to add.
Yeah,
One thing that we'd like to bring in is that, if you look at the West, there is a huge propensity for using ciprofloxacin or levofloxacin as oral antibiotics for eradication of Pseudomonas or treatment of bronchiectasis in many of these patients. But I think in our scenario, given the TB, the number of patients that we have, I think that is something that we need to stay away from.
So you would strongly discourage usage of fluoroquinolones?
Absolutely.
So
Yes.
Kasi, you want to say something?
Sir, here in pediatrics, handling cystic fibrosis is very difficult. So for 14 days, we'll not get any IV lines. Hardly we'll get 2 to 3 days or 1 week, because talking management of cystic fibrosis is totally different when you're managing a cystic fibrosis child, because diagnosis is expensive, treatment is expensive, even death is also expensive and painful. So here thing is, what I want to give a message is, instead of going a blind thing, there is a role of bronchoscopy. If there is an organism, try to isolate the organism and give an appropriate antibiotic. Instead of that saying that the Pseudomonas, Staphylococcus, H. influenza, going an empirical therapy, try to isolate the organism, give the appropriate antibiotics, give appropriate treatments, which can prevent the resistance. Because every 2 months or 3 months, the child will be coming with an exacerbation. Every time you give a meropenem, meptaz, ultimately will be no landing with no other antibiotics. So here what I'm trying is, the role of flexible bronchoscopy you can do. Here is the one of the condition where role of flexible bronchoscopy for a ball is a cystic fibrosis. Isolate the organism, give appropriate antibiotics. That is the one thing, and followed by the physiotherapy.
But if you see in the clinical scenario, Dr. Kasi, what happens to the patients is they come, quite often, as you rightly said, at least they would be requiring 5 to 6 admissions in a year. So every time they come, they'll be example. I want to quote an example. First admission, they'll come with pans and Stubber. By the time fourth admission, they'll be harboring the MDR bugs. So it is very, very vital. So to start empirical antibiotic as soon as you see the exacerbation. So what is important is, kindly note, please make a note of, what was the pattern of Pseudomonas or other bacteria in the previous admission. And if it was sensitive, then probably you should hit really hard and fast to control the exacerbation. So you upgrade the antibiotic, send the cultures and then upgrade the antibiotic, and then follow up the cultures and then adjust the antibiotic and de-escalate the antibiotic. That would be the very, very practical approach in these patients.
One thing that I'd like to add over here, as Kasi has explained beautifully, the role of bronchoscopies. One difference that, the practically what we see as compared to what we would just read in literature, we all associate cystic fibrosis with thick mucid secretions, viscous secretions in the airway. But what we don't realize is when these patients come into the hospital, when they're sick, and when we actually scope them, they've been on so many mucolytics, they've been on so many mucokinetics, they've been on so many nebulizations. When you put in the bronchoscope, it's like tap water. You have their airways are completely filled with secretions, and these are not that viscous. And once you hit the suction button on the bronchoscope, it is never ending. It just keeps on flowing. It just keeps on flowing. So doing bronchoscopies on them is not very easy as well. Plus, what we need to remember is these secretions are not what you're going to send for analysis for your cultures. You need to clear off the airways, which itself is a daunting task. And then you need to perform a good bronchoalveolar lavage to know that what actually is the colonizing organism there.
A thorough toilet bronchoscopy is mandatory, but what is most important in such patients is there may be concomitant carpulmonary hypoxia. Handling hypoxia is also becomes a very, very difficult task. Dr. Richa, can you please add your experience here?
Yeah, so I completely agree with Apar, what he's saying. So I was just saying that bronchoscopy is not always feasible in these patients. They might be hypoxic, they may be really sick, and we may not be just doing a bronchoscopy to, get the what is the mechanism in that. And it is really difficult, as I completely agree with Apar. So bronchoscopy may be needed when you are expecting thick mucus plugs, which is causing the collapse of the lungs, to clean that, or there are secretions retained where you want to clear it up, but or you want to make diagnosis of a specific bacteria or mycobacteria. Only in that scenario, I would suggest. Or if you have to look for, cause for newly onset hemoptysis, or you are looking at some other diagnosis.
So that also brings me, making me think of Apar. Do you think is there any role of if the patient is having a focal bronchiectasis by somehow? Is there any role of surgery like lobectomy, pneumonectomy in such cases?
If the patient had to have the disease, this would be the better disease of the lot, that they have focal bronchiectasis and not a widespread bilateral bronchiectasis. Yes, definitely. Once their FEV1 starts falling, lobectomy is the choice of surgery for them. So these are the patients who would escape a transplant and would do well with just a lobectomy.
Right. Here, Dr. Soumya, my colleague, is asking, what is the cutoff, or what are the important points that I need to consider to differentiate between pulmonary rehab and lung transplant? Soumya, it is very, very important. All the patients, should undergo pulmonary rehab. Pulmonary rehab plays such a very, very crucial role in management of cystic fibrosis, whereas lung transplant, as Dr. Apar rightly mentioned in the earlier discussion, it has to be carefully selected, and we have to medically first optimize these patients, and overall nutrition status has to be optimized before considering for transplant. Dr. Frenzen from Puducherry is asking, any dose modification required for CFTR modulators when the patient has a, coexisting ABPA and is an antifungal? Can you please take?
I have no answer to that. Huh? I have no answer to that, Vijay.
Practically, it is. We are talking about a rare disease, and he is adding a rarest combination. Anyone would want to comment on this?
It's a rare combination, and the answer that he is seeking is not available in India.
Absolutely. So let's go back to our discussion, Apar. See, classically, when we see adult patient with bronchiectasis, we do give them probably a month or 1.5 months of antibiotics. Or as per guidelines, if we want to follow, at least 3 months of antibiotics should be given to eradicate the bug from the bronchiectatic airway. What is your take in cystic fibrosis?
See, from whatever I remember from my training days, I don't think we've ever been able to eradicate the bugs from these airways. So that is why if you look at all the literature or the treatment guidelines for cystic fibrosis, it's just a treatment of colonization with an aim to eradicate, where 28 days on and 28 days off is what is typically practiced. So typically tobramycin was the drug, or aztreonam in certain centers have been used, where more resistance patterns with pseudomonas have been found, and continuously till the patient gets a transplant, 28 days on, 28 days off is followed. Azithromycin was quite recently introduced, and there again, like in typical bronchiectasis, we use it for a period of 2 years and then we sort of give it a gap. But here 250 milligrams on alternate days 3 times a week is used continuously till the patient goes towards a transplant.
But it is also a very difficult task for you people as a transplant pulmonologist to take such cases where they are harboring resistant bugs. What is your comment?
Actually, Vijay, these are the best cases. So if you look at worldwide data, bronchiectasis and cystic fibrosis bronchiectasis, these cases actually do best. They have the best survival and they have the least morbidity. They have the quickest recovery times post-transplant. The only care that we have to take is during the surgery. Like if I can just go into a little bit of details, one is a proper tracheal toileting has to be done. Once the trachea is, dissected out, once at the bronchial level, if you are doing a bilateral lung transplant, once the recipient bronchi have been dissected out, we have to make sure that one, the pump suckers are not used so that the infection does not go into the blood. Two, a good toileting, has to be maintained into the trachea from the bronchoscopy and from a retrograde from the bronchus end where it has been cut has to be done before the new anastomosis is done. And I think that really takes care of most of the infections. Post-transplant, definitely all the bronchiectasis patients, like typically we keep our patients on a piperacillin tazobactam combination post-transplant. But these are the patients we would go for colistin nebs, IV colistin empirically for up to 5 to 7 days post-transplant, because of course these are the ones who harbor more infections. Right. But yes, it is very rewarding because they come out flying.
So Dr. Santosh is asking you, Apar, what's the recurrence of, he's from Telangana, Hyderabad. So what's the recurrence of bronchiectasis in post-transplant patients?
As I said, there is no recurrence of bronchiectasis in post-transplant patients, except for a very few reports wherein for homozygosity for some rare mutations in the CFTR gene, few reports have been there in childhood where recurrence has been noted. Other than that, typically, as an overview, if I can say, there is no recurrence of bronchiectasis in these transplanted lungs.
Dr. Jagruti from Maharashtra, again asking you particularly, how should she prepare the kids' family that she has discussed for a lung transplant, and then what is the approximate cost of it?
So lung transplant approximately cost in our country at any of the centers which are practicing is about 40 to 50 lakhs. Now, for a pediatric case also, it will be there. So I think if the family has to be counseled, it should be done in conjunction with any of the centers or any of the transplant physicians who've had experience with managing children where transplants have been done. So get in touch with one of the transplant centers, get those physicians, get those surgeons to be involved when you're talking to the family. And I think that would be the best way forward.
Right. So Dr. Stuti and Dr. Bajpai has texted me. You both are talking for longer time. Okay, can't you ask some questions? So they are becoming angry on us. So coming to Dr. Stuti, okay, can you please, disease progression in cystic fibrosis, is being measured by various parameters, both the nutritional parameters and pulmonary function tests. Can you please throw some light on how do you monitor these patients?
Yes. So it is a very multidisciplinary approach. I can't just say I'm a pulmonologist and I'll be just doing a spirometry and be monitoring with that. I have to give a holistic care to the patient, and we have to see multiple indices. See, first of all is the nutrition status of the patient. The easiest way to do is the BMI, and then we can do the height and the weight. For the lung functions, for very young patients, it's very difficult for them to get a spirometry done. The typical curves that we see for the patients at an exacerbation, their FEV1 is dropping. I think it's very difficult when you send a patient for such patient for PFT. Most of them would not be able to perform it. So you have to rely more during exacerbation. You have to rely more on the clinical sign, the subjective feeling that the patient is having. Is he complaining of increased cough? The normal things we see in bronchitis is whether the quantity of sputum, the color, and the odor has increased, the respiratory rate. So during exacerbation, we need to rely more on these clinical signs. Now, once your patient is off the exacerbation, I think we need to do a monthly sputum culture so that we are more aware about the organism that is growing, and then we can decide whether it's a colonization or an active infection. And then it goes on to antibiotic stewardship, what to be given, what need to be eradicated. And apart from that, nutrition really needs to be assessed. BMI is one way, and then the lean body mass index is also very important, sir. At times, what happens with the pancreatic replacement therapy? These patients are taking high calorie diet, and their BMI might increase because of the fat content, but the lean body mass, the muscle mass, would be very less. So, impedance can be used to see that. So,
Right.
these are the parameters we need to see, sir.
Dr. Ankit, anything you want to add here?
Definitely, I agree with Dr. Stuti. We have to look into totality for these patients for the assessment. As for the respiratory function, you have to assess the nutritional assessment also, and the other system, organ system other than the lungs needs to be assessed for the follow-up and for the disease progression.
Right. Thank you, Ankit. Can you, what are the various determinants of early mortality? Ankit, in cystic fibrosis.
That is very important factor that is we have to assess in the patient. Type of mutation is very important. If we can categorize it by our analysis, as we know that type 1 to 3 and type 7 are particularly more severe. So we have to look into that prospect also. Now, the nutritional status is a very important prospect in these type of systemic cystic fibrosis patient. If your patient has a very poor nutritional status, he has a very low BMI, then maybe we are heading towards an early mortality. Now, the most important prospect is the lung infection, that is the pulmonary disease, the recurrent infection, the type of bugs you are getting, the extent of disease you are having. You have more of MDR bugs, drug-resistant bugs. So these are the particular predictors for early mortality in cystic fibrosis patient.
So we should try to eradicate, but as Dr. Apar mentioned clearly, so it is very, very difficult to eradicate bugs from these lungs.
Yes.
And can I ask
the number of exacerbation also I'd like to add. How many
Yeah.
exacerbation the patient is having in the year, that is also a very important determinant.
Right. So, Dr. Jyoti, can you please suggest our audience? So, what do you replace the pancreatic enzymes, and then how do you replace these enzymes in these subset of patients, these set of patients?
So as we know that the second most common symptom is related with pancreatic insufficiency after the lung. So most common symptoms pancreatic insufficiency are like weight loss, bloating, gases, dyspepsia, loose stool, greasy stool, sticky stool, and failure to thrive. And there is no weight gain in adults. So whenever any patient having a cystic fibrosis and having these kind of symptoms, then we have to look for the pancreatic insufficiency. Some of the patient of cystic fibrosis also have pancreatic sufficiency. They are also in a PS kind of PS phenotype of cystic fibrosis. So it doesn't mean that all the patients are suffering from cystic fibrosis have a pancreatic insufficiency. Some of the asymptomatic pancreatic insufficiency patients are also there. So this syndrome or this symptom is most common in less than 1 year of age, and 90% patients are suffering from pancreatic insufficiency who diagnosed with cystic fibrosis. This abnormality is very, I think, rare in adult population, but those are suffering from these kind of symptoms are having a pancreatic insufficiency. So as we know, this is a cystic fibrosis disorder of the glands, where like in pancreas there is a defect in exocrine glands. So there is a deficiency of amylase, lipase, and proteases. So there is difficulty in digestion of protein, carbohydrate, and fat. So this is a reason behind the greasy, fatty stool in cystic fibrosis. So for this, as Dr. Apar has also said, that pancreatic transplant is not the option. So we have a good drugs like pancreatic enzyme replacement therapy we have for the management of these kind of patients. One more thing I would like to highlight here: those patients who are suffering from pancreatic insufficiency, there are greater chances of lung dysfunction. They are suffering high severe kind of lung diseases. So, and one more important thing, whenever how to diagnose these pancreatic insufficiency. So, this is a, I think there is a one gold standard test. It is a quantitative estimation of the fat in stool, but it is a very cumbersome, it is a very inconvenient test to diagnose this pancreatic insufficiency. So, one another test is available with us is fecal esterase 1 identification of fecal esterase 1. So this is a very good tool for screening of pancreatic insufficiency. It has a high predictive value. It is a good test to rule out pancreatic insufficiency. If this parameter is more than 200, then there is a chances of pancreatic insufficiency are rare. But if this value is less than 125, there is a positive predictive value of sensitivity is very high, about 70%, specificity about 87%. So I think this is a test for screening of pancreatic insufficiency in our domain. And treating these patients, one thing is more important. Any patient who is having cystic fibrosis and symptom of pancreatic insufficiency, without doing this test, we can start pancreatic enzyme replacement therapy. This is very important. So whenever the test came out, you have to start this therapy. When test came out negative, you can stop it. But we have available porcine derived pancreatic enzymes, and they are gelatin based capsule, and they work in very good. And the doses depends on the basis of the patient weight as well as the fat content in our meal. So as per the weight of the patient, we have to recommend 500 to 2500 units of lipase per kg per meal. And this drug should be taken along with the meal. If patient is taking a proper meal, these drugs should be taken with the meal. And they don't have to crush these medication, and they don't have to break these medication. This is very important. So there are very minimal side effects of these drugs. They are very safe when they are taking properly. Dosing and method of taking these drugs is very important. So I think this is all about the pancreatic enzyme replacement therapy. And as well, along with the pancreatic enzyme replacement therapy, we all have to give fat soluble vitamins also. We have to test for the first fat soluble vitamins levels, and as per the like A, D, E, K, we have to supplement vitamin A for good eye care, and vitamin D for the good bone care, and E and K also to be given to our patients as per the deficiency level.
So it is very, very important to replace these enzymes, and then vitamins, fat soluble vitamins is most important in management of cystic fibrosis patients. So yes, we know the final endpoint is transplant, but before transplant, there are various things, because if you see across the globe, the survival of these patients from second decade, it was probably 2 decades back, they were surviving into the second decade only. But nowadays they are surviving into fifth decade and sixth decade as well. So there are a lot of things that have changed the quality of life of these patients apart from medications, as we have discussed. I would request Dr. Kasi to comment on what are the other measures to help in preventing the exacerbation in these patients. Dr. Kasi?
Yes, sir, as previously said, so giving an appropriate antibiotics for appropriate duration, so we'll try to decrease the colonization or decrease the organism. That is the one thing. Second thing is we need to airway clearance techniques. So the good airway clearance techniques, the lesser the amount of secretions, the lesser the amount of colonization, the lesser the amount of contamination also, sir. So that is the one thing. And mucolytics, where you can prevent the secretions, and antibiotics, as you said, like in anti-inflammatories like azithromycin for 2 years, like that. Again, we can prevent some colonization. So, and yearly influenza vaccine is also we can prevent better than rather than the exacerbation. These are the things, sir, which
So
can
what are the
prevent
various
exacerbation.
airway clearance devices?
Yeah. airway clearance is that is a effective clearance therapy is one of the component of cystic fibrosis, sir. So all airway clearance is what they want to do is they'll increase the intrapulmonary pressure, which will in turn transmit to the secretion. It loosens the secretion. Again, the child or adult will start coughing out. So in that there are one is mainly is a postural drainage and percussion technique, sir. Again, it increases the intrapulmonary pressure, translate to that secretions, thick secretions. It loosens. Again, it will come out. Same way, active cycle of breathing techniques, autogenic drainage, and positive expiratory pressure and oscillative positive expiratory pressure, and the high frequency chest compressions. Again, translating the pressure to the intrathoracic, loosens the secretion. Again, try to get the secretions out by coughing, sir. These are the airway clearance techniques, sir.
Dr. Richa and Dr. Apar, do you want to add anything here for airway clearance devices or techniques?
Richa?
No, I think Dr. Kasi has very well told about it. So, yeah.
See, I think starting from the drugs, using simple things like N-acetylcysteine, then Dornase alpha, which may or may not be available many of the times, and then adding on the devices. I think starting with very simple devices like our a cappella, like the lung flute, and then moving on to percussion devices, the vest. Now there are Indian companies which are making the vest. Previously, it was very difficult because each vest that you would import from the US would cost you something close to 6 or 7 lakhs. But now the same thing is available for 25 or 30K, which has been developed from the companies based out of Delhi. And then for advanced cases where you have a lot of secretions, things like cough assist devices, where, as Kasi was explaining, using the pressures, using oscillatory methods, we can loosen out the sputum and help bring that out as well. And then ultimately, yes, when patients do land up in exacerbations, bronchoscopic clearance techniques for bronchoscopic toileting. I think all of this has to be employed whenever and as needed for all our patients.
So to add to this, I was going through the literature. There is something that I have seen in the Google. There is something called de-suppurating device or something. Okay, which will also help in facilitating the clearance of the loosening of the mucus and then clearance of these secretions from the given patients. I know it's already 9:45. So we all great things, good things at some point of time will come to end. So I would request all the panelists, particularly Apar, hope we have covered everything. Anything else you want to communicate here?
I think very, very nicely from, starting from the etiologies, pathogenesis, the genetic typing, the mechanism, clinical features, radiological features, the various treatment options, medical, non-medical, airway clearances, transplant. I think very cohesively we've covered most of the topics that we could.
Can I take a final one-liner from you?
Complex disease, but something that we need to keep in the back of my mind, with something which we cannot forget.
Richa?
I think we should not just consider that this disease belongs to the pediatric age group. We need to open our eyes and brain also open that it could be seen in adult population as well. So awareness is must.
Right. Dr. Bajpai?
So from my side, symptomatic management is the backbone of the cystic fibrosis. So I think newer drugs are making very buzz like Levacaptar, Evacaptar. But from my side, symptomatic, we can't forget our basics. So like antibiotic, mucolytic and clearance, airway clearance, postural drainage. These are the backbone for the management of cystic fibrosis till now.
Dr. Ankit?
We cannot keep this disease as the disease of the West. So we always have to look for possible diagnosis whenever we are assessing our patient. Yes, this could be a possibility. I know there are Herculean tasks after diagnosing it, but still you should keep in mind that you should diagnose cystic fibrosis.
Right. Dr. Stuti?
So we are picking up more cases, but I think as we have seen, the drugs are difficult to get. Diagnosis is costly. So I think we should remember the basics. Our basics we should do. Timely vaccination. And the most important is to teach these patients chest physiotherapy. the majority of the patient we will see in our practice will not be talking about elixacaftor or ivacaftor. I'll be happy if he just does the physiotherapy and follows it, just protects himself from the pollution. So I think all the big things apart, we need to keep the basics in mind. That is what we'll be doing with the majority of the patient, and that's just my main point.
Dr. Kasi, the pediatric pulmonologist.
So you should consider cystic fibrosis as one of the differential diagnoses for the recurrent or persistent pneumonia, and you have to strengthen the tools of newborn screening. The earlier diagnosis, the better prognosis. We should give this take-home message to all the listeners today. So try to diagnose at earlier age. So if you want to diagnose earlier age, you should have a good clinical knowledge of cystic fibrosis right from antenatal to the adult age.
Thank you, Kasi. Thank you, one and all, for such a wonderful discussion. All the panelists have contributed to their best. So we always think cystic fibrosis as a non-existent in this subcontinent, but it is not so. We do come across. Only thing is, it is very, very important to, as I was mentioning, the red card theory. So we need to keep low threshold to keep cystic fibrosis as one of the differential in our clinical practice, to identify it early and then manage appropriately, so that the life expectancy, if you look at the West, definitely the life expectancy has gone way up in the past 2 to 3 decades. Nowadays, patients are surviving till 60 years as well. So that's to match and the Western standards, it is very, very important. We have to diagnose the disease early. And there is definitely, from medication point of view, I request the CCI core members to tag the central government as well, so that for this rare disease, the medication should be available in India rather than importing them at a huge price. It is, as Apar was clearly mentioning, it is almost impossible to import these drugs, and then the cost of care is, as Dr. Kasi was mentioning, close to 6 crore per annum. It is impossible in Indian scenario. So I request central government authorities to pitch in and then facilitate these drugs available at a cheaper price for Indian patients. And lung transplant, once it was a nightmare, 5 years, exactly pre-COVID time, it was a nightmare, okay, to think and suggest lung transplant. But with the presence of stalwarts like Dr. Apar and so many working across India, okay, it has become really doable and affordable as well to some extent. So, so with this, I would love to conclude, and I must thank okay, the CIPLA and then technical team for their relentless efforts, because CCI is the only pulmonology body that across India that is doing non-stop webinars for the past 3.5 years. 3.5 years doing non-stop without the technical support, it is an impossible task. Thank you, CIPLA. Thank you, technical team, Vinod and Bansal. Thank you, Vipul. And most importantly, the core team of CCI, that is Dr. Atri, Dr. Ravi, NH Krishnanna, Narayan Pradeepa, Anil Maske, and Dr. Shivani, so Dr. Kirat. So really, okay, my heart, sincere appreciation for permitting me to do this, one of the rare topic in Indian subcontinent. But with this, and we will catch up with the next CCI webinar next week at the same time, next Thursday. Thank you. Signing off.
Thank you. Thank you, everyone. Good night.